Distinguished experts, dear colleagues from China as well as from Europe, good morning and good evening. So, because we're in different time zones, that's why we have chosen this time to conduct our meeting. So, for today's meeting, we'll focus on the updates of this year's ESMO meeting. So, we have many new readouts of the clinical trials, and also we cover the HR positive and HER2 positive breast cancer treatments, especially for HR positive treatments for MONARCH-E study. We know that for the first time, we have the absolute benefits of the OS. So I think it's going to change our clinical practices. So we are very happy to have foreign experts join today's meeting. And at the same time, we are also joined by Professor Yu Yuan from the Zhejiang Cancer Hospital. At the site, we're also very happy to have Professor Sun Zhenghui from the Jiangxi Cancer Hospital. And so we're also very happy to have other distinguished experts join today's meeting offline. So the first speaker is Professor Gennari from Italy. And she is from the UPO. She's from University of the UPO and the head of the Division Oncology. So over to you, Professor Gennari.
Thank you. Thank you very much for this invitation. And good afternoon, I think, is there to all the colleagues. Wait a moment that I try to share my slides. Okay, you should see it. Can you confirm? Okay, so my task today is to present data from ESMO conference on the latest progress in intensified adjuvant strategies for early breast cancer. These are my conflict of interest. So let's start from the available guidelines for the treatment of early breast cancer. As you can see here, of course, all our topics and recommendations are divided and are different in the different subtypes of breast cancer, estrogen receptor positive, HER2 positive, or triple negative. And let's start from the estrogen receptor positive, HER2 negative early breast cancer. Here we have our main issues. So we must assess the risk of recurrence in terms of anatomical and biological risk. Then we must define who really needs chemotherapy. And we must also define where and when we should use intensified endocrine therapy by the addition of CDK4/6 inhibitors to endocrine treatments or extended endocrine therapy. We know, of course, that clinical pathological factors are important in defining the risk of recurrence, as it depends from the extension of the disease, including nodal status, tumor size, and tumor grade. But this is not enough, since we have also to define who really benefit from the addition of chemotherapy in this endocrine sensitive patient population, and we do this by using gene expression assays in breast cancer. So we have a clinical pathological definition of the risk, and we have also a genomic risk of recurrence. As far as endocrine therapy is concerned, we have seen in the past years that the intensification of endocrine therapy results into an improved outcome. You see here in the first data from tamoxifen by no endocrine therapy. Then we had the introduction of aromatase inhibitors. Then we have different duration of aromatase inhibitors. And finally, we have the demonstration that by further intensifying adjuvant endocrine therapy by the addition of CDK4/6 inhibitors, we can improve the outcome of these patients with a reduction in the risk of recurrence, good quality of life, benefit in overall survival. So we know that the risk of recurrence in after primary breast cancer treatment is time dependent, and we know that in higher risk patients, the risk of recurrence is higher during the first 2 to 3 years, and then it declines with more time. Actually, there are 4 trials that try to attempt the role of the addition of a CDK4/6 inhibitor in high-risk patients. So far, we have 2 trials that are positive, Monarchy and Natalie, whereas the 2 Penelope P and Pallas trials, including adjuvant or neoadjuvant palbociclib, did not meet their endpoint of improving the outcome of these patients. As far as the 2 trial, Monarchy and Natalie trial, there are some difference between these 2 trials in the definition of high-risk patients. In the Monarchy, we have only not positive patients, and also some biological factors such as the proliferation rate is taken into account. Moreover, all endocrine treatment pattern were possible, including tamoxifen, whereas in the Natalie trial, only aromatase inhibitors plus or minus LH-RH agonist were possible, were included. Other difference, as in the route of in the administration schedules, ABEMA can be assumed every day, twice per day, whereas Ribo at the dose of 400 milligram per day is administered for 3 weeks on and 1 week off. But possibly the most important difference is in the disease stage, since in the Natalie trial, also patients with node-negative early breast cancer were allowed. The risk was further defined by the use of a genomic test. Here are the most important difference. So as you can see here in the Monarchy, patients at higher risk of disease with not positive breast cancer were included, whereas in the Natalie, also patients at lower risk were included, or those patients with high genomic risk. The Monarchy trial is a trial that was presented for the first time a few years ago. Now all patients have terminated their endocrine therapy. Here, treatment was administered for 2 years. So patients are in follow-up currently. The characteristics between the 2 arms were well balanced, especially when you take into account the use of adjuvant or neoadjuvant chemotherapy that was actually administered in the vast majority of the patients, whereas only 5% more or less of the patients were chemotherapy naive. This is because, of course, this was a high risk patient population. So here we have the updated results in terms of invasive disease-free survival. We have now an improvement by 6.5% in the invasive disease-free survival for an hazard ratio of 0.73. This means that there is a risk of reduction in invasive disease-free survival by 67%. This is the analysis according to neoadjuvant and adjuvant prior chemotherapy, and both these groups failed. Both these groups were benefiting from the addition of ABEMA, with no difference between these two schedules, these two approaches. There was also a poster by Miguel Martin, which clearly showed, taking into account the proliferation rate, that clearly showed that if you take into account, of course, patients who received the neoadjuvant chemotherapy, that high Ki-67 is, of course, associated with a negative outcome compared with low Ki-67, but the benefit of the addition of endocrine therapy with abemaciclib is consistent in these two groups, regardless of the Ki-67 level. The same was observed when you take into account the modification of Ki-67 post-neoadjuvant chemotherapy from baseline through cut to pre-surgery to surgery samples, and actually patients whose tumors remained high Ki-67 post-neoadjuvant chemotherapy, of course, they had the highest risk of recurrence, but all patients benefit from the addition of abemaciclib regardless of the change of Ki-67. And I think this is really an important point in this patient population. Distant relapse-free survival was also consistently improved after 6.3 years of follow-up, favoring the abema arm, and also when we take into account the median overall survival analysis, and this is the first evidence of this, at the median follow-up of 6 years, the combination of abemaciclib plus endocrine therapy reduced the risk of death by 15 point, almost 16% is compared to endocrine therapy alone. And this is a very important data because it is the first demonstration that the addition of a CDK4/6 to endocrine therapy in the adjuvant treatment of high risk early breast cancer luminal patients improve the overall survival. And as you can see, this improvement can be seen in all the subgroups that were taken into account, and also the percentage of patients who are alive with metastatic disease is improved in those patients who received abemaciclib plus endocrine therapy, 14% versus 20%. If we take into account which is the systemic anti-cancer therapy in the first-line treatment of the metastatic setting, this is a data that it is particularly important because you know that all major guidelines, they indicate that patients fail after adjuvant endocrine therapy and by becoming metastatic, they should receive subsequent endocrine therapies, because these, unless they show primary endocrine resistance, but and as you can see here, actually the use of chemotherapy was reduced, especially also in those patients that were experiencing an early recurrence. So they were treated with endocrine therapy. So there is a difference in the use of chemotherapy between arms that was primarily observed in early recurrence, and it was less pronounced in later recurrence, because in later recurrence we are used independently from the use of adjuvant abemaciclib to use another endocrine treatment. The Natalie trial now was with more mature data. So in the Natalie trial, there were, as we were saying before, also patients with node-negative early breast cancer that were enrolled. These data are at this pre-specified analysis at 555 months, and now also this trial is more mature. In fact, in the vast majority of patients are in the follow-up phase, so they stopped the treatment, and only 27% and 24% of the patients are still receiving adjuvant ribo. There is a confirmed benefit in terms of disease-free survival, favoring the ribo arm, with a reduction in the risk of invasive recurrence by 29%. And when you look at this data, separated by the presence of node-negative disease or node-positive disease, we have now a statistically significant benefit favoring the use of ribociclib also in node-negative patients. And this is very important. This is the distant relapse-free survival analysis. Again, fewer patients are alive with metastatic breast cancer in the ribo arm than in the arm who received only therapy, endocrine therapy. And this is more clear in this data where you see the histogram, and it is clear that fewer patients are experiencing metastatic breast cancer, favoring the ribociclib arm. The overall survival data from this trial are, of course, too early to be seen. There is a positive overall survival signal favoring the ribo plus endocrine treatment arm that it was observed, but in any case, this data is really immature so far. So, in conclusion, when we treat endocrine receptor positive, HER2 negative early breast cancer, we evaluate the risk of recurrence by anatomical and biological risk factor. We define who needs chemotherapy by the use of genomic test and by the integration between clinical and genomical risk. And then we have a strategy of intensifying endocrine therapy that now is a consolidated approach in high-risk early breast cancer, including node-negative and node-positive disease. And finally, we have the first evidence that abemaciclib is significantly increased overall survival in this high-risk patient population. When we go to the HER2 positive early breast cancer, we must take into account two issues. The first one is that we know that if you have a HER2 positive early breast cancer, T2 or more or not positive, the use of neoadjuvant chemotherapy plus trastuzumab or trastuzumab plus pertuzumab is a winning strategy. And this is because we know from several years that the achievement of a PCR in HER2 positive early breast cancer is a predictor factor for a longer survival. And we know from this very important patient-based meta-analysis by Cortazar 10 years ago. At ESMO meeting, we had two important trials, including trastuzumab deruxtecan, that were presented. The first one is the Destiny Breast 11 trial. This is, again, a randomized global multicenter phase 3 trial where patients with previously untreated early breast cancer at high risk, so more than T3 and node negative or 3 plus, or inflammatory breast cancer, or CT4 are not positive, so CT from 0 to 4 are not positive, were randomized to receive the deruxtecan, followed by for 4 cycles every 3 weeks, followed by TCHP, so the classical treatment with Taxol, taxane, trastuzumab, and pertuzumab. And in the control arm, there was dose-dense anthracycline-containing regimen every 2 weeks, followed by the 3-drug regimen, the THP. So we can say that this arm, including anthracyclines, may be considered a little bit old now, that we are used not to use anthracyclines anymore in the early breast cancer treatment in HER2 positive disease. However, this trial randomized patients with that were the vast majority with not positive, almost 90% with not positive early breast cancer, HER2 positive, and as you can see, these are the results in terms of pathological complete response rate, and actually there was an improvement by 11% in patients treated with deruxtecan in terms of response rate, pathological complete response. So the use of neoadjuvant deruxtecan followed by THP demonstrated a statistically significant and clinically meaningful improvement in pathological complete response versus dose-dense doxorubicin cyclophosphamide for 4 cycles versus docetaxel, trastuzumab, and pertuzumab. And these are the subgroup analysis, and basically all patients were having an improvement in terms of PCR rate. That was the primary endpoint of this trial. These are the other outcomes with residual cancer disease after neoadjuvant treatment, and actually there is a trend also for an improved event-free survival favoring the deruxtecan arm with a hazard ratio of 0.556 that was not reaching the statistically significance, because maybe this trial is still immature, but there is an early positive trend that should be taken into account. The treatment that were administered in those patients with residual disease must be taken into account, because there is a large proportion of patients who did not receive salvage TDM1, which is recommended by the major guidelines. But the safety profile was good. No new signal of unexpected toxicity emerged, and so basically we had the third arm in this trial, but it was closed on 2024 because following independent data monitoring committee recommendation, because actually there was a difference favoring the conventional dose-dense ANTRA followed by PHP, and so trastuzumab deruxtecan alone showed inferior but robust PCR compared with the 5-agent sequence of chemotherapy. Although event-free survival data were similar, but the monitoring committee decided to close the deruxtecan arm all. So when we come to what we can do after surgery in those patients with residual disease, we know from the Catherine trial that the use of TDM1 is superior to trastuzumab. And the Destiny Breast 05 study was addressing this particularly unfavorable patient subgroup, so those patients with residual disease in the breast and axilla. These patients were randomized to receive 14 cycles, 1 year, of deruxtecan every 3 weeks versus TDM1, which is considered the standard of care. And as you can see here, the vast majority of these patients actually had a positive nodal status. And this is a very important point, because this is a high-risk patient population. And as you can see here, actually the use of the deruxtecan was associated with a reduction in the risk of relapse by 53%. So there is an important risk reduction by using the deruxtecan as compared to TDM1 in this unfavorable, prognostically unfavorable patient population. This is the invasive disease-free survival analysis by the subgroups, showing that virtually all groups achieved a benefit from this, also in terms of distant recurrence. So these are the data on the disease-free analysis, and all this data favor the use of adjuvant deruxtecan in those patients who have still disease after surgery. Adverse events were similar, also in terms of radiation pneumonitis, which was possibly one of the most important fears in this trial, and also in terms of ILD and left ventricular dysfunction. The treatment was very well tolerated, taking into account there is a superimposition with adjuvant radiotherapy. So the conclusion for HER2 positive early breast cancer, there is, although we don't have a biomarker to identify which patients need treatment intensification other than the clinical data. So we still have to define which adjuvant therapy in patients with residual disease after the deruxtecan or THP, because the Destiny Breast 05 is not answering this point. And finally, there was no comparison with the actual standard, that is the combination of paclitaxel, carboplatin, trastuzumab, and pertuzumab without anthracyclines. As far as the adjuvant therapy, we still have to define if it is better in terms of toxicity to use deruxtecan plus concurrent or sequential radiotherapy. We have, of course, the problem, should we give deruxtecan in the neoadjuvant or in the adjuvant rescue setting? And then we are still to define the reduction in the central nervous system metastasis occurrence. We have also data in early triple-negative breast cancer. Again, the achievement of a PCR in this unfavorable patient population is a surrogate of an improved overall survival, and in this patient population, we use adjuvant immunotherapy when we have node positive disease. But we have also some toxicity from adjuvant pembrolizumab. So this is why the PLANET trial is very important. The PLANET trial randomized patients that were candidates to be treated with neoadjuvant immunotherapy plus chemotherapy to receive a lower dose of pembrolizumab in addition to chemotherapy. So they received only 3 cycles of pembrolizumab, 50 milligram per square meter, every 50 milligrams, overall, every 6 weeks. And actually, this trial showed that there was a benefit favoring the use of low-dose immunotherapy, of low-dose pembrolizumab, as compared, of course, in this trial with chemotherapy alone in this patient population. This was also in the ETT analysis and also in the analysis in those patients who underwent surgery. No new signal of toxicity, and actually the toxicity was very mild in this patient population. However, no comparison between 2 different doses of pembrolizumab was performed, because we have a conventional dose and schedule of pembrolizumab that we use now in the clinical practice in this high-risk patient population, but this trial did not take this into account. So they showed that lower dose of pembrolizumab is active in improving PCR as compared with chemotherapy alone, and actually also a small sample size, including only roughly 160 patients. But this data is very important because they tell us that it is possible to reduce safely the dose and schedule of pembrolizumab to achieve a better tolerance of this drug. And with this, I would like to thank you for your attention.
谢谢呢，我呢非常感谢呢 General 教授呢，其实就二
Thank
零二
you.
五年 ESMO 当中
Thank you,
做了一
Professor
些临床研
General,
究呢，跟大家
for
做了很
the
好的一个
kind
分享。
sharing
这里
on
请教呢
the
金教授呢，
updates
可以
of
顺便
the
到前
ESMO
高
meeting,
阶的临床研究的
especially
方
for
案，
the
在
HR
第一个
positive, HER2
记忆
negative
防
early
类
breast
型防
cancer
疫方案提供
patients
的这个生产
consolidative
的后援，
treatment
这是第一个
because
可以对我
we
们的临床实
for the
践呢
first time have
最
the
大的帮助。
OS
那第二个，我们想关注的
benefits
是
that have
核压
been
性的治疗
verified
当中，
and
如何
also
把
another
非低血
important
药
part is for the HER2
来
positive
替代我
patients.
们常规
How
的
can we
化疗
use
药
the
来提
ADC
升
drugs
它的一个
to
生活质量，
replace
同时呢
the
降低药
traditional
物相关的不
treatments
良
and
反应？
also to
特
further
别是
reduce
在
the
三型的代
toxicity,
战中，尤其是特
especially
别
in
是在
triple
肾上腺
negative study
更低
for
的剂
the
量的帕
pilot
布利度的
study. I mean, at the
在
lower
相关的
dose
化疗技术
for
上也可
pembrolizumab
以同
based
样的
on
可以
the
增加
chemo,
PCR 率。
we can
尽
also
管它的
further
技术非
improve
常
the
好，但是
PCR.
PCR
I
的实际
understand
使用
sample
率达到
size
了
is
10%，
small,
基
but
本上可
actually
以推到额
absolute
外研究底
benefit
下的
is
医生所相
13%.
似的别
I
的
mean,
别的
similar
相关的
to
个别
the
的领
keynote
域
study,
获得
meaning
相对
that at the
的
lower
提
dose
升的一个
of
预期。
pembro, we can
非常感
also
谢曾理教授呢，在
improve
这
the
个
benefits to the
刚刚
patients,
推行的
improve the
最新的这个
PCR.
在 ESMO 的这
Thank
个
you,
报告
thank
非
you,
常感谢。
Professor
那我们这个
Yanari,
环
for
节
your
呢，接
kind
着呢，就
sharing.
我
So
们讨论
in
环
this
节，
part,
在这个讨论环节呢，我们
I
有
mean,
该介绍的江西省肿瘤
I
研究心理
think
中心的主任
we
孙正好
also
博
gonna
士，
have
还有我
the
们江
discussion.
西
I
省肿
think
瘤研究
Professor
所
Sun from
黎阳
Zhejiang Cancer
这个
Hospital
叶万
and
教主任，
Professor
所以
Yu
呢，他们
from
都有非
the
常丰富的临床经验，
cancer
特别
from
是基
the
于刚才的演讲呢，主
Jiangxi
要提供
Cancer
在辅
Hospital.
助和新的
So
组织的
just
范
now
畴，
we
提
had
供
the
患者治理的
discussion
手诊来说，
about
大
new
概
adjuvant and
非常
other
重要。
adjuvant
它能
treatments.
够
I
分切
think
了人
for
工
new
呼吸，同
adjuvant
时在这个环
treatments, I
节，
mean
我
they
们
are
也非
also
常
very
欢迎 General
experienced.
教授继续加
And
入，
also
我们
for
可以
this part,
保持很好
I
的一个
think
互动。
Professor
那
Gannery
我
can
们根
also
据
stay
议程
online.
当中
So
的规定
according
模
to
式呢，我
the
们可以在白板当
agenda,
中所提出
so I
啊。
think we
那
can,
现在开始讨论吗？
I think,
好，那我们也根据议程的设计， 我
sorry,
们也
according
请
to the
General 教授稍作
agenda,
休息。
I
第二
think
位的教授呢是来
Professor
自于美国耶鲁的
January we
郑
can
荣松
take a little
啊，
break.
是我
We're
20
gonna
位的
have the
教授，
second talk
他也
first and then have the
是
discussion
耶鲁
together.
美国耶
And the
鲁
second
癌症
speaker
中心
is
乳腺部，
Professor
也是
Lasbeck.
耶鲁癌
She
症中
is
心乳
director
腺
of
癌
the
医学
cancer
肿
for
瘤学
breast
的首
cancer
席专
at
家。接下
Similar
来他
Cancer
会提
Hospital
供我们非
at
常
Yale Cancer
有意
Center
义的一个讲
and
题。
chief of the
那这
breast
个讲题
medical
呢，其
oncology at
实也
Yale
是
Cancer
对
Center.
于乳腺癌
She's
跨
also
向
gonna
免疫
share
面
with
部的
us a
ADC
very
治疗热点的
interesting
一个讲
topic,
题，也恰
hot
恰是
topics in
反映了我
targeted
们乳
therapy,
腺癌治疗最新的
immunotherapy,
解禁。
endocrine therapy,
那我们
NDC
欢
therapy
迎
for breast
教授呢
cancer.
为我们做
So
精彩
over
的
to you,
演讲。
Professor Landsberg.
Thank you so much, and thank you for the audience for being here for this discussion. We are going to switch gears to some of the updates that were presented in metastatic breast cancer during the ESMO meeting. I will start with two abstracts in hormone receptor positive metastatic breast cancer. So this was an interesting poster, the again study presented from Japan. And it asked the question of if we have patients who have been treated with an endocrine therapy agent plus abemaciclib, what happens at the time of disease progression if we re-challenge them with abemaciclib while changing their endocrine therapy partner? So if they were on aromatase inhibitor or tamoxifen, they would be switched to fulvestrant. If they were on fulvestrant, they would be switched by AI. And the part of the study
Recording
design,
stopped.
part of the study design was based on the reported studies of an older study known as the post-monarch study, where similarly this was a switch strategy where patients on CDK4/6 inhibitors upon progression were switched to fulvestrant plus abemaciclib versus fulvestrant alone. And I'll come back to this study as a comparison after I present these studies. So back to the AGAIN study, as you can see, a majority of the patients, 2/3 of the patients were postmenopausal, and a good proportion of them actually had good disease-free interval, showing kind of an element of endocrine sensitivity. 2/3 had visceral metastases, and what the study showed in this small study is that when the patients on aromatase inhibitor and tamoxifen and abemma were switched to fulvestrant plus abemma, median progression-free survival was 7.1 months. However, when patients were on fulvestrant previously, and when they were continued on abemma and switched to an aromatase inhibitor, progression-free survival was 2.8 months. When we look at the different subgroup analyses in terms of progression-free survival, patients showing elements of endocrine sensitivity were more likely to be benefiting from this, again, switch strategy. Patients with postmenopausal status tended to be more likely to benefit, as well as patients who had not previously received chemotherapy. So I think, again, this study is intriguing. It's a small study, but it's the first study to re-challenge our CDK4/6 inhibitor from abemma to another abemaciclib challenge, and putting it in the context of the earlier reported post-MONARCH study, essentially very similar PFS results, and showing a much more modest result when we're switching from fulvestrant and aromatase inhibitor, which makes sense because we do know that endocrine resistance as well as ESR1 alterations do happen in this population. So how do we put this in the context of all the other studies that have been reported to date showing different switch strategies with CDK4/6 inhibitor? And in this slide, you have both the post-MONARCH study as well as the MAINTAIN study, PALMERA study, and the PACE study. And the principle of all these studies was that essentially there was a switch strategy with the CDK4/6 inhibitor. And in this table, you can see that the majority of the prior CDK4/6 inhibitors with these studies was palbociclib, and then they were switched to either abemaciclib, ribociclib, and palbociclib, as you can see there. So again, very modest results in terms of progression-free survival of anywhere from 4 to 6 months, very much in keeping with what this abstract is showing. Moving on to this next abstract, this was a study that compared 3 phase 3 trials based on trying to understand the efficacy of imlunestrant, which is now a newly approved selective estrogen receptor degrader, in combination with abemma, and trying to do a cross-trial comparison with 2 other reported studies, MONARCH 2 as well as post-MONARCH. And seeing how does fulvestrant plus abemaciclib compare to fulvestrant plus imlunestrant. As a reminder, the EMBER-3 study design is listed here, where patients with metastatic breast cancer were randomized 1:1:1 to imlunestrant alone. Standard of care therapy, which did not include a CDK4/6 inhibitor, and imlunestrant in combination with abemaciclib. So the investigators wanted to look at this imlunestrant plus abemaciclib and take results from MONARCH 2 and post-MONARCH and essentially do a cross-trial comparison, seeing how fulvestrant plus abemma compared to imlunestrant plus abemma. So all the limitations of cross-trial comparison, of course, apply here, but they did try to look at these through well-balanced factors, taking into account the race, region, and the number of metastatic sites, as well as balancing out the prior exposure to CDK4/6 inhibitor. And when they did that, again, limitations acknowledged that this type of cross-trial comparison is more it is an exploration. It's not definitive. They showed that essentially the PFS and hazard ratios really favored imlunestrant plus abema. So again, suggesting that perhaps imlunestrant has more activity relative to fulvestrant. So again, limitations are noted, but certainly interesting data that PFS favored imlunestrant plus abema across all three methods that were looked at. So how do we put these two abstracts in the context of our current landscape of how we treat patients with hormone receptor positive breast cancer? This is getting to be a very complex space in the second line setting. We're currently in the United States as well as many parts of Europe. We have two selective estrogen receptor degraders approved for patients with ESR mutation, for patients with PIK3CA and AKT or PTEN loss. We have capivasertib, and for patients with PIK3CA alterations, we also have alpelisib approved. And then for the patients who do not have mutations, I think this is the space where these abstracts particularly apply to, where if your patient's tumor does not have known genomic alterations, some type of a CDK4 sequencing or switch strategy can certainly be considered in the absence of a clinical trial. And we also don't want to forget about patients with germline or somatic genetic alterations because the PARP inhibitors continue to be a very important option. So lots of choices here, and we do not have a lot of data, as you saw, in terms of direct comparisons among these approaches. What I don't cover in this presentation, but was discussed also in ESMO, is that we have a number of new SERDs that will also be entering the scene, including giredestrant as well as camizestrant. So a lot of new data will be coming in the coming months in terms of trying to tease out how to pick among these different combinations. But at this point, the most important takeaway is understanding the genomic alteration of your patient's tumor, as well as their prior endocrine sensitivities, are the most important decision points in terms of selecting among these many treatment options. Switching now to triple negative metastatic breast cancer, several important studies were presented in this year's ESMO, starting with the ASCENT-03 study, which was a randomized phase 3 study in patients with metastatic or inoperable triple negative breast cancer that were previously untreated and were not candidates for PD-L1 inhibitors, and that could be that they had PD-L negative tumors, or they had PD-L positive tumors and were previously treated with a PD-L1 inhibitor in the curative setting, or for a number of health conditions, they were not a candidate for receiving a PD-L inhibitor. They needed to have been greater than 6 months since treatment in the curative setting, and stable CNS mets were allowed. The schema is listed here, and you can see that over 500 patients were randomized 1-to-1 to sacituzumab govitecan, which is a TROP2 antibody drug conjugate, versus standard chemotherapy that included either a taxane or a gemcitabine and carboplatin doublets. One of the most important takeaways from this study is that the patients were eligible to cross over to receive sacituzumab in the second line setting if they were initially randomized to the chemotherapy arm. And moving on to the results, so the demographics are listed here, and a third of the patients had de novo metastatic disease, and good performance status. About half the patients were going to go on in the control arm to receive taxanes, and about 45% were selected to have by the investigator, by the treating physician, gemcitabine plus carboplatin. A third had liver metastases, and 59% had lung metastases. So as you can see, very remarkable PFS results with a median progression-free survival of 9.7 months compared to 6.9 months. And you can see this translates to a hazard ratio of 0.62. The 6-month PFS rate with the antibody drug conjugate was 65%. And as you can see, there are unfortunately those early progressors that progress no matter what what arm they're on. This is that very aggressive, rapidly progressive triple negative breast cancer subtype. But for those patients who are able to achieve that initial stability, you can see by 6 months, there is a clear, significant separation of the curve, and certainly more so at 12 months. And there is a subset of patients, about 10% of patients, that continue to have disease stability even at that 2-year mark. Benefit of sacituzumab was seen over chemo across all key pre-specified subgroups, as you can see here. Duration of response was 12 months with sacituzumab and 7.2 months in chemotherapy groups. 41% of patients had a partial response in the sacituzumab arm, and 41% had stable disease. Duration of response, as we saw, was substantially longer with sacituzumab over chemotherapy. Back to the most important point, that there was crossover allowed in this study, which was very important and laudable and really important for patients. Progression-free survival 2 was 18.2 months in the sacituzumab arm versus 14 months in the chemo arm. And overall survival results are currently immature, but may be impacted by that important crossover that was allowed. Rates of grade 3 and treatment emergent events were similar with both groups. However, it's important to know that unfortunately there were 7 deaths that were noted in the sacituzumab arm. Many of these were related to secondary to neutropenia and infection. There was less primary prophylaxis with G-CSF agents that can make this agent much more safer if they're used more preemptively. You can see the adverse events listed here, where again, no new safety signals were identified with sacituzumab, with neutropenia and nausea and diarrhea leading the way. So again, an important study that showed that earlier use of an antibody drug conjugate in this first-line setting led to a 38% reduction in risk of progression or death, and progression-free survival 2 was also longer, and rates of discontinuation were lower. And I think with more preemptive use of G-CSF, the agent can certainly be a much safer agent to use and important for this population. There is a competing antibody drug conjugate in this setting, Dato-DXd, datopotamab deruxtecan. Both the Begonian study and the Tropion study, 01 study, were presented. This Tropion study was a phase 1b/2 multi-center, multi-arm study, and in this year's ESMO, arm 7 were reported for any patients with triple-negative breast cancer with any PDL expression, where they went on to receive Dato-DXd, which is another TROP2 ADC in combination with durvalumab. And you can see smaller study, but really impressive results in that patients' responses were observed in both PDL high as well as PDL low tumors. And you can see the confirmed objective response rate was quite high, and the median duration of response was 17.6 months, and median progression-free survival was 8.3 months. Expected toxicities that we see with datopotamab, including stomatitis and nausea, were noted. And we know that this can be mitigated with the use of dexamethasone mouth rinse. Tropion Breast 02 was also presented in this year's ESMO, and this was the randomized phase 3 study comparing Dato-DXd to investigators' choice of chemotherapy. This is a similar population to the Ascent 03 study that I just presented. Again, this first-line triple-negative setting. And you can see, again, very impressive, high objective response rates, significant progression-free survival was noted, as well as the duration of response of median duration was 12 months relative to 7.1 months with traditional chemotherapy. Overall survival was noted also in this study, which is important. However, patients in this study were not allowed to cross over, which led to a lot of interesting discussions in this year's ESMO about the ethics of whether patients in this very aggressive subtype of breast cancer, how important it is to allow a crossover, but it may impact some of your subsequent analyses, including overall survival data. So I think the most important takeaway for these two abstracts is that we clearly have practice-changing data that earlier introduction of antibody-drug conjugates in this first-line setting is quite critical for patients with metastatic triple-negative breast cancer. This is important because if we wait, many patients may not go on to receive that second-line ADC, and now we have, at least with one study, an overall survival advantage reported with this first-line ADC use. And then the last bit is to focus on HER2-positive metastatic breast cancer, and this was a study from China, the Horizon Breast study, looking at SHARE-A 1811 compared to the pyrotinib doublet. So this is a trastuzumab rezetecan is a HER2-targeted antibody-drug conjugate that has been developed in China, and it has shown in previous study to have good efficacy in HER2-positive breast cancer. As you all know, pyrotinib plus capecitabine, which was the comparator arm in this study, is the approved second-line treatment in HER2-positive breast cancer in China. And so this was the phase 3 randomized study for patients who have been previously treated with a taxane and trastuzumab in the metastatic setting, and they could be in their second or third line setting, and they were randomized to this HER2 ADC versus the pyrotinib capecitabine doublet. You can see that the majority of the patients had visceral disease. all patients had received trastuzumab previously. About a third of patients had also received pertuzumab in combination with trastuzumab. The majority of patients were in their second-line setting, having progressed on that first-line chemo trastuzumab combination. As you can see, extremely impressive PFS results were reported with a 12-month PFS rate of 84% compared to 35% with the pyrotinib capecitabine doublet, translating to a hazard ratio of 0.22. PFS advantage was seen in all pre-specified subgroups, as you can see here, favoring the antibody drug conjugate. By line of therapy, whether patients were in their second or third line, we're seeing similar benefit. And similarly, if patients had also received prior pertuzumab, again, we're seeing a similar advantage, a very impressive separation of curves very early on, and this median progression-free survival of over 30 months when the HER2 ADC was seen. You can see the comparison of the toxicities reported, and what I do want to highlight the interstitial lung disease numbers here at the bottom. The rate was 2.8%, which is lower than the currently approved HER2 antibody drug conjugate trastuzumab deruxtecan. So that was important. Standard neutropenia, nausea, and GI liver function test abnormalities were seen with the HER2 ADC. So the conclusion is that this is certainly absolutely impressive results with a median progression-free survival of 30 months versus 8.3 months with the doublet pyrotinib capecitabine. And the safety profile is very favorable with low incidence of interstitial lung disease. And I think this is an important study that how do we put this in the context of the other agents that are currently approved. So as you all know, the DESTINY-03 study would be the comparable population to the Horizon study here. And this is the trastuzumab deruxtecan study compared to here, and when the median progression-free survival was further updated and reported in 2023, the median progression-free survival was 28.8 months. So very similar to the Horizon study. And so then the question becomes, how do we put this newer HER2 ADC and how do we put it in the context of trastuzumab deruxtecan? I think, as you can see, the efficacy seems to be similar. Well, likely there are going to be drug availability and cost differences between the two. So if this is more inexpensive, if it is, or if it's more accessible in China and other parts of the world, then that's certainly an important advance. And then in terms of toxicity differences, I think it's important to really, again, highlight the interstitial lung disease differences. In DESTINY-03, 15% of patients develop ILD, where here it's less than 3%. So I think that is an important difference. Now we have the DESTINY-09 study that just got published, where now the HER2 ADCs are even being evaluated in that first line setting. And soon the PATINA study will be published, looking at patients with triple positive, HER2 positive, who have responded to that initial ADC treatment, patients who have been treated with trastuzumab, pertuzumab and taxane and have disease stability, then they can go on and have maintenance treatment with palbociclib in combination with trastuzumab and pertuzumab. And that study also showed a very promising PFS results. So I think we are looking at a very very rich space right now with a lot of different options. So I'm thrilled that we have another HER2 ADC that may make these type of therapies more accessible in other parts of the world, but lots more discussion in terms of how we will choose among these agents. So in summary, we had exciting results in all subtypes of breast cancer for metastatic disease in this year's ESMO, and we're continuing to make advances with better drugs and better options and better combinations, but lots to learn still in terms of how to personalize our treatments, select the best treatment for each individual patient, and how to reduce toxicities. Thank you so much for having me and look forward to the discussion.
好的，非常感谢我们来自美国耶鲁癌症中心 Lasberg 教授呢，就我们乳腺癌
Thank you, Professor Lasberg, for the sharing on targeted therapy, immunotherapy, endocrine therapy, and ADC therapy for advanced stage breast cancer. How can we better improve the survival of those patients nowadays? We have new readouts of those studies. So, I mean, for HR positive patients nowadays, we should also check the ESR1 mutation. And so if it is positive, we can use oral SERT. And for triple negative patients, we can use TROP2 ADCs like SG, based on SN03, or Dato-DXd. Nowadays, they are also in the first line. For HER2 positive advanced stage breast cancer patients, TDXd, it has become standard care in the second line in this year's ESMO meeting. And so Professor Song Wei also shared with us the 1811 ADC, and also compare against the control arm. It has better PFS. So no matter is the TDM1 or TDXD or the ADC drugs or the A1811, they have better performance than the control arm or the standard care. So I think for those innovative therapies, they are able to improve the quality of life of the patients and also improve the survival. I want to thank two distinguished foreign speakers for the sharing on the updates of this year's ESMO. So we're gonna have very interesting panel discussions soon. So right now, for this part, we have Professor Sun Zhenghui and Professor Yu Yang. They are very experienced in clinical practices. They also have a lot of academic achievements. So I'm very happy to have the two professors join today's panel discussion. Without further ado, we will kick off today's panel discussion. So for the first question, I think it is also based on ESMO updated monarchy and Natalia study. So for HR positive, HER2 negative early breast cancer patients, what are the regimens that they would choose? And what are the reasons? We know that for the two studies, they have different inclusion criteria. They have different follow-up time. They also have different survival data. I understand two drugs have been approved, but I think for AE profile, it is also different between the two drugs. So firstly, I think I will give the floor to Professor Zheng Hui to share his insights with us. Okay. Thank you. Thank you, Professor Chuan Gui, for the kind introduction. I also want to thank the foreign speakers for the wonderful sharing based on the updates of the monarchy and the Natalia study in this year's ESMO. And so for the HR positive, HER2 negative early breast cancer patients consolidative treatment. So for the monarchy and the Natalia studies, they already disclosed other preliminary data in the past. In China, for the two drugs, abemaciclib and ribociclib, they have been approved in the adjuvant setting, but indication is different for abemaciclib. It is approved to treat high-risk EBC patients, and for Natalia study, and so indication has been approved to treat intermediate high-level risk patients. But for MONARCH-E, the highlight is that it has the OS positive data. So I mean, for the early breast cancer patients, the OS benefit is indeed a marvelous achievement, because for the endocrine treatment after tamoxifen, we didn't have any positive OS study yet until we have MONARCH-E. I understand the absolute benefit is 1.8. We still have the statistical significance for this delta. So for the two treatment arms in abemaciclib arm, the non-breast cancer mortality is even higher if we exclude non-breast cancer-induced mortality. Actually, the breast cancer-related benefits could be even higher. So I think it gave us higher confidence to choose abemaciclib with the OS benefits. So that's the first part about the OS benefits. In addition to that, for the DFS, we also observed the sustained benefits of it. The HR value is also beneficiary. I didn't see the absolute number of the HR benefits. So I think with 2 years treatment, we have 7 years DFS benefits. This is indeed impressive, because for Natalia's study, we know that ribociclib has to be utilized for 3 years. But for adjuvant treatment with consolidation, 2 years and 3 years, which one is better, we're not sure. And so for some experts, if we use the drug for 3 years, we're able to cover the peak time of recurrence, but with shorter treatment duration, with greater benefits, I think it's going to be better. So, I mean, nowadays we have the 7 years data. We know the second peak of relapse is year 7 and year 8 after diagnosis. So I think abemaciclib is the preferred one, but of course we need to consider the safety. We know that for abemaciclib, it has the GI toxicity. And so if patients cannot tolerate GI toxicity, we may use ribociclib. But for ribociclib, for patients that have not been covered by MONARCH-E, like for the lymph node negative patients with high risk factors, we can only use ribociclib. We're not sure whether abemaciclib will benefit those patients or not. Therefore, for abemaciclib, indicated patients, we need to use ribociclib. So for high-risk patients, if they have good tolerability of abemaciclib, I would still prefer abemaciclib. Another important factor is that right now in China, abemaciclib can be reimbursed, and this is also a very important factor to choose it, because the affordability and accessibilities are something that we need to take into consideration. So thank you very much. I think Professor touched upon the sustained benefits, the treatment duration, as well as the reimbursement. I think he has covered very comprehensively. So Professor Yu Yang, I think you also have your own understandings for abemaciclib. For example, if the indication is overlapping with the lymph node positive patients' indications in Natalia study, how would you choose between the two drugs? So for MONARCH-E, we for the first time have the positive OS data. What will be the impacts? Thank you, Professor Chang Gui, for the kind question. So for this year's ESMO meeting, we know Monarch E and Natalia all obtained sustained benefits. So, on one hand, for high-risk HR-positive alternative early breast cancer patients, of course, we need to utilize CDK4/6 inhibitors to consolidate treatment because so for Monarch E and Natalia, we have two studies to be complementary to each other. For those population, we need to do consolidated treatment in the adjuvant setting. For high-risk population, how can we make the choice? And so for patients that are indicated for Menaki and Natalia regimens, maybe they are also indicated for Dicyclib. So how can we choose the regimen? There are several factors need to be considered. Firstly, we need to check the guideline. Guideline recommend all of them. The second factor is the level of the evidence or the source of the evidence as well as the observation and the follow-up time of the study. Because from NACE, we already have 7 years follow-up. For Natalia study, the follow-up is 5 years. The longer the follow-up is, the higher the evidence is, and the more maturity the data will be, which will give us more confidence. And OS is, of course, very important because for adjuvant treatment, the main purpose is to cure more people because we hope that we can cure more people with the prolongation of the OS. We can cure more people. So I think it will give us more confidence to choose abemaciclib because for Monarch E, for 7-year follow-up in the background, it states that for tamoxifen versus non-tamoxifen, we reduce the 30% risk of mortality for AI. Based on that, we have further reduction of mortality risk, indicating that for those patients, we need to do consolidative treatment. The fourth point is that, like Professor Zheng mentioned, that a very important thing is about the AEs and the side effects because of different patients. They may have different profiles, and for elderly patients with the cardiac toxicity, they are not indicated for Natalia regimen, but for patients if do a lot of business travels, diarrhea will be a huge problem for those frequent travel patients. So maybe abemaciclib is not so suitable for them, just like Zheng Kui mentioned. Abemaciclib in the early stage adjuvant treatment, it can be covered. Ribociclib has not been covered by reimbursement, so we need to use the reimbursement drugs to further reduce the disease burden and financial burden for our patients. Thank you. Thank you very much for the kind sharing. So we need to emphasize that HR-positive HER2-negative ABC patients, CDK4/6 inhibitors should be added in adjuvant consolidative treatment. And so for Monarch E, we have longer follow-up, especially for this year's meeting, we have the positive OS data. And so the third thing is about the AE consideration as well as the reimbursement. So for the reimbursement, I think in the future, the other CDK4/6 inhibitors would also be covered. So these will all the factors that will be considered. So we know that for Natalia study in this year's ESMO, the lymph node negative patients have also got positive data for the first time. So I have the question for two foreign experts. Actually, how do you view these positive data of lymph node negative patients? And so based on Natalia's study, we'll use the ribociclib to treat the N0 patients. Professor Ganari, could you take this question? Professor Ganari?
Yes. So basically, the question
So for N0, N0 patients.
Well, for N0 patients, you know that this can be only treated with adjuvant ribo. The data from ESMO clearly showed that now we have a benefit in terms of disease-free survival also for this lower risk patient population. But we must remember that this patient population is at lower risk if we compare this to the node-positive patient population, but it is still at a higher risk of relapse as compared to other node-negative patients. I think that here the balance must also take into account, well, first of all, this evidence. There is a benefit in terms of invasive disease-free survival also in node-negative patients. But, however, we must also take into account that this treatment may be related with some level of toxicity. There is a 3-year treatment duration, which may not be easy for all patients to be compliant with this regimen. Take also into account that you have to take the drugs for 3 weeks, then a week they will not take the drug, and then they will start again. You need also to look at the blood counts, for instance, before administering this drug, even if you do this every 3 months. So I think that we should balance this new data with the patient that we have in front of us. Not all patients might benefit. Take also into account the elderly patient population. When we talk about estrogen receptor positive early breast cancer, we have that the vast majority of patients is in postmenopausal patients, and postmenopausal patients may be 75-year-old patients. We must also take into account comorbidities that are frequent in this patient population. So I think that these data, which are of course important, but they need to be individualized based on the characteristics of the patients that we would like to treat. This, I think, is an important point, because you administer an important treatment. It's not like endocrine therapy alone. This is a treatment, different treatment, can have problems and this type of problems may be more present if the patient is an elderly patient with polypill treatments for other type of comorbidities, and also they must be able to take this drug for 3 years. So I think we have to shape this data on the patients that we have in front in our clinical practice.
好，谢谢，好，谢谢郑瑞教授。我想大家
Thank you, Professor Gennari. I think you have already heard the translation. And for N0 patient benefit, indeed, we need to interpret in a very objective way, because we need to consider whether there's absolute benefit from the treatment, and also we need to consider the toxicity and whether there's over-treatment. So a comprehensive consideration is necessary, and also we might need the data to be more mature. Now, individualized treatment is very important. We still need to wait for example, stratification data, even though currently we haven't had that. So for N0 patients, for some of the high-risk patients, maybe it's more suitable approach. So thank you very much, Professor Gennari. And now let's move on to discussion topic number 2. And I think Professor Gennari has also talked about this for the HER2-positive patients. For Destiny Breast 11 and Destiny Breast 05, we have talked about the intensified therapy in the adjuvant setting, etc. And also we've talked about the use of ADC. So will the latest result from DB11 and DB05 change the current perspective? So will we prefer the new adjuvant ADC use, or prefer to use ADC in the adjuvant setting? That's intensification. Professor Chen, please. So now after TDXD and THP, we can see that PFS has been significantly improved. There's 11.2% of improvement. So for HR positive, it's 9.1%, and for HR negative, it's 16.1% of improvement. So I think from the data, of course, we should use ADC, but still we need to carefully analyze
in terms of the patient being enrolled, they're more high risk. They're usually patients with a bigger tumor or node positive. So if we're going to use these approaches, then we probably still need to use it in more high-risk patients. And also, we need to look at the EFS benefit, because for DB05, now with the DB05 result, we start to think, should we use it upfront or wait until there's residual disease? So we still need to wait for EFS benefit. And we have seen some EFS benefit already in terms of the EFS event in the control arm. I think there's 18 events. For the study arm, there's only 13 EFS events. So data-wise, it looks pretty good. But like mentioned by our speaker, it's been compared to DDAC-THP. So now we are mostly using TCHP in China. So EFS actually start from randomization. So probably we also calculated the new adjuvant setting period as well. So if we compare to TCHP, we have no idea about the efficacy and safety. Maybe TCHP will have better safety. So for now, I think for neoadjuvant setting, I think the study results so far will not change my practice unless for very high-risk patients, probably considering patient circumstances, I might consider ADC, but so far it won't change my practice yet. For the neoadjuvant and adjuvant intensification therapy, I think this will probably change our practice more because we start with the TDM1 comparing to trastuzumab. So basically, for some of the studies, they are only comparing to one anti-HER2 therapy, but now DB05, they have compared to TDM1. So basically, the best therapy available already. And also, DB05 had very good DFS benefit. I think there's a delta of 8% or something. So comparing to the best comparator, such an improvement, actually, if possible for me, I probably would use TDXD as intensification therapy. But of course, we need to pay attention to the patient being enrolled. It's also high risk and also was node positive after neoadjuvant therapy. And also for TDXD, for this study, there's also toxicity concerns and also death cases in the study. So if we're going to use it in practice, then perhaps only in high risk and the residual node positivity patients, and also pay attention to the toxicity and safety. So that's my opinion. Thank you, Professor Zheng. I think for these two DB studies, you have emphasized for non-PCR patients in the adjuvant setting used as the intensification therapy because of its IDFS benefit, and also it better fits our current practice. I would like to invite Professor Yu to join the discussion as well. I have actually a question. In DB11, since we use DDAC followed by THP, and like mentioned by our speaker, this is not TCHP or not the current standard of care. So for DB11 using DDAC-THP as a control arm, what do you think about this study result? And also, will you use the DB05 approach, or do you prefer to use the DB11 neoadjuvant treatment? Thank you, Professor Song, for your question. To be honest, this year for DB11, of course, DB05, we have the DB11, DB05, and before we have DB09. And TDXD always compared to best available therapy and has always demonstrated great result. So that's a very good thing. For the first question, the EC followed TPH and TCPH, which one is better? Or basically for the adjuvant setting, we think the EC followed by TPH and TCPH, in theory, the efficacy is pretty much the same. So for EC followed T and TCBH, basically after adding H, the two regimen has the similar efficacy. And also in affinity study, we did not specify we should use EC followed by TPH or TCPH. So basically, we haven't had data to show TCPH is better than EC followed by TPH. So from this perspective, I think for EC followed by TPH, in a neoadjuvant setting, it's not inferior to TCPH. In terms of cardiac toxicity, maybe it's slightly higher than TCBPH, but the efficacy will be pretty much the same. And according to DB11, we can see from this study, for DB11, similar Christine study, it has validated that ADC alone is not very effective in the neoadjuvant setting for HER2 positive. So the ADC will have to combine with chemo targeted therapy so that it can be better than conventional targeted therapy. So now, when we use the current DB11 result in our current practice, I think we need to carefully select our patients. I agree with Professor Zheng. If we're going to use this regimen, we can improve the PCR rate. But what about patients who are non-PCR? What should we do? Is there any way that for the non-PCR patients, we can intensify the therapy? So far, we probably have no treatment options yet. So from DB11, we can see that after TDXD and TPH for RCB0 and RCB1 proportion, it has been significantly increased. So the patient can be downstaged for breast conservation surgery, axillary conservation surgery, etc. So if we're going to have neoadjuvant therapy and convert to surgery, DB11 is a good option. But if the surgery is our goal, then can we actually eventually improve survival? There's still a question mark. For DB05, will we use that in our practice? Of course, DB05 has great IDFS result. But to be honest, in my clinical practice, I would not use that regimen because we know TDM1 after dual HER2 blockade has demonstrated very good result and reduced relapse by 50%, and at 7 years achieved the OS benefit. For DB05, even though there is significant IDFS benefit, however, if the patient progress, what can we do? So if TDM1, patient progress on TDM1, we have TDXD. But from DB03, we can see TDXD comparing to TDM1, the 2-year EFS, it's 28 point something to 6 something. So after crossover, there's also a discounted result. So for such patients, we still need to wait for data for OS result, because after TDXD, we need to think about, can we still switch back to TDM1 and have good result? And of course, for patients who failed TDM1, if they later switch to TDXD, they can still do very well. Thank you, Professor Yu, for your comment. You have shared with us for DB11 and DB05. I think you prefer to adopt DB11 study result. Thank you for the comments. And I would also like to ask Professor Generi online. Actually, in DB11 study, we can see DDAC followed by THP. Basically, also showed 5% of ILD. And previously, for AC followed by THP, we did not pay attention to this. So my question to Professor Generi is how to explain that. So for patients who did not use TDXD, they still have similar ILD incidence, and why is that? And also, I would like to ask Professor Generi, in clinical practice, should we adopt DB11 or should we use DB05 and use ADC in adjuvant setting? And my third question is, like Professor Generi mentioned, radiation therapy is very important. For DB11, it's basically after neoadjuvant setting, patients still have positive lymph node or patients who are inoperable before neoadjuvant therapy. And in DB05, there's also patients who have positive lymph node and require radiation. So for radiation and TDXD, how should we sequence these two? Because the radiation therapy and TDXD may both have impact on ILD. So what do you think, Professor Generi?
Well, thank you for this question. It's difficult one, to be honest. The first question is about the occurrence of ELD also in the chemo alone arm. What I think is that basically now we are looking for ILD in these patients after the demonstration that it is in any case present in a minority of patients with the Ruxtecan, but these patients are now in the early breast cancer setting and they may be cured. We must also say that this patient population is particularly at high risk, so it has an extension of disease that it is in the range of locally advanced disease. And we must also take into account the fact that we have a high pathological complete response rate. And as you know, in this patient population, the achievement of a pathological complete response may be a surrogate of overall survival. So this is very important in terms of the possibility of achieving a cure in a superior number of patients and also in patients with a higher risk HER2 positive early breast cancer. However, we do not have yet data on event-free survival, so possibly what we can say so far is that we achieve a higher number of pathological complete response, and this might turn into an improved survival according to the data that we have actually in the literature. The other point is if I would prefer DB11 or DB05, this is difficult as an approach because and also taking into account, let's take into account everything, also the DB09, okay, in the metastatic setting. So we have to understand first of all when is the better time point in the clinical evolution of high risk, not positive, HER2 positive early breast cancer patients to introduce the Ruxtecan. If it is upfront, if they have a locally advanced disease, and maybe my answer would be yes, in this patient population, even if we don't have a direct comparison with the TCHP without anthracyclines, but in any case, anthracyclines are a very active drug in the treatment of HER2 positive breast cancer. We don't use this anymore because we have the double block with pertuzumab and trastuzumab, and of course we have a regimen that it is more manageable and less toxic in terms especially of cardiotoxicity. The other point is that TDM1 is also an active drug in the treatment, in the post-neoadjuvant treatment of these patients. So I think that also here we may wait for more mature data in terms of long-term event-free and possibly also overall survival. But for sure, we will have to shape the sequencing of this treatment because also we do not know if for all patients the upfront use of the Ruxtecan in the first-line treatment of HER2 positive metastatic breast cancer is a winning strategy. Take also into account the data from the PATINA trial in HER2 positive disease with estrogen receptor positive. And of course, these data are very important. So we might shape the algorithm, taking also into account all this other evidence that we have, because maybe for an hormone receptor positive metastatic breast cancer, triple positive metastatic breast cancer, the best treatment option is the Cleopatra regimen followed by the combination with palbociclib. In that case, as in the PATINA trial, or in any case with the CDK4/6 inhibitor. So I think that it is too early to discuss this, but for sure, if I would have the possibility to use the Ruxtecan in an HER2 positive, node positive, locally advanced early breast cancer, I would use it.
Thank you. So I understand we have a lot of data, and sometimes not all those regimens will be practiced very soon. I mean, for TDXD, the CDK4/6 emitters. I mean, we still need to wait for more data to figure out which regimen is the best. So we will change to question 3. So question 3, it is more about advanced treatment. Professor Lasberg just now shared with us a very wonderful talk. So for the third question, I will give the floor to Professor Yu Yang first. So based on the new data, I mean, for neoadjuvant therapy with low-dose pembro with chemo achieved promising efficacy in early TNBC, and so can we use this regimen? And according to ASCENT-03 study, will the clinical practices be changed? Thank you for your kind question. As the surgeon, I can handle the first question very easily. For TNBC patients, I think it is also aligned with Keynote study, meaning that for TNBC patients neoadjuvant treatment, we should add on the immune therapy so PCR can be further improved, which may also give us more efficacy. And in this clinical trial, we see pretty good result. I think this is not about the immune therapy de-escalation. The chemo is also de-escalated because we didn't have platinum in it. And so if we add on the low dose immunotherapy and PCR can be around 60%. Therefore, for certain TNBC patients, we have higher confidence. But of course, this study has some shortcomings because this is not phase 3 study with a relatively small sample size. Therefore, in clinical practices, for those low-risk population, in neoadjuvant setting, we cannot only consider chemo de-escalation, but also immune de-escalation for advanced stage BC patients. I mean, as the surgeon, normally I will not treat advanced stage patients, but for ADC drugs in all lines of the settings, the efficacy has been proved and verified. But of course, we need to remember the toxicity would also be difficult to manage. So for the SG, I mean also for Dato to DXD, and so I mean for the mortality risk is higher than the chemo, and so we actually see 7 deaths in the Dato DXD arm. So I mean for the good drug, of course we can have very good efficacy, but this should be based on the good observation. Thank you very much for your kind sharing. So we know that in the study, we have very good regimen because we remove the platinum, and so we use the low dose pembro, and that the dose is only 1/10 of the standard dose. So I think on one hand we can improve the efficacy, on the other hand we can also de-escalate the treatment. Thank you, Professor Yu Yang. So Professor Zheng Kui, what's your comment on this question? So for triple negative breast cancer patients, according to domestic international guidelines, we use TCB sequenced with the AC. We know that there are 4 chemo with the immune for grade 3 toxicities are very high, which is around 70%. So whether all the patients need to use such a potent regimen, I think, of course, we need to dive deeper into this question. This is also well worth of exploration, and that's why we have the exploration of de-escalation of the treatment. No matter it is the chemo or immunotherapy, we try to de-escalate the treatments. So I think it is worthwhile to do those studies. But who are the patients can enjoy the de-escalation? For PATINA study, we know that they use lower dose, 50 milligrams 3 times. It is less than 1/10 of the Keynote study dose. Results are impressive. PCR has been improved by 11.3%, and so the definition of PCR is very stringent, is 10 T0 N0. So the standard is actually very stringent in this study, and I think the benefits may be underestimated. So the data is impressive, which is close to our 522 study, but sample size is very small. Why the sample size is so small? Because at the design, the threshold has been set as 20 and single side alpha is 0.05. So the sample size is very small. So I think for this study, this can only be the basis for future explorative studies. Therefore, in clinical practices, for low-risk population, I try to de-escalate the chemo. I will not de-escalate immunotherapy just based on this data, because for the immune-induced toxicity, normally it's going to be like it is going to happen or don't happen. It is not so dependent on the dose for the toxicity. So, I mean, the data is not that solid. That's why I still need to see more data to support the escalation of immunotherapy. So right now, I would just de-escalate chemo instead of the de-escalation of immunotherapy, because in China, we also have several other studies. And in terms of the cost, like the PD-L1 from local companies, the price is very low actually in China. So I would not consider to de-escalate the immunotherapy for the second question. Actually, for the triple negative patients treatment in first line setting, if they have positivity of the PD-L1, and so no matter it is PD-1 or above 10, and so standard care is the immunotherapy with chemo for those ineligible ones. I mean, for ESLIN study, as well as 0102 study, as well as the SQSR study from China, my personal thinking is that TROP2 ADC is better than chemotherapy, but the toxicity management is also something that we need to manage. But nowadays, we have more, experiences, and so I think we nowadays have more experiences. So I think for those patients, I think I would also use those regimens. Okay, thank you very much. And so currently speaking, actually based on Keynote 522 study, we have dual primary endpoints, no matter it is improvement of the DC. And I mean, for patent study, it is a phase 2 study. And actually, it has given us a very good basis for the future studies. So in the future, we would also looking forward to, further improve the PCR rates. And so we need to wait for phase 3 studies to, do more, have more data. So Professor Nansberg is also online. So I have a question for you. For phase 2 study, how can we translate to phase 3 studies? Whether it is actually being implemented for low dose pembro with the chemo. What is your view on the future prospect of this regimen? And what if we can implement this? What is the right timing for us to introduce this regimen? Professor Landsberg.
Yeah. Yes, thank you for that question. I agree with the previous discussants that it's still, it's a smaller study. It's an exciting study. I think it was an important study that was done in India, where patients have to self-purchase vials of immunotherapy. So the fact that less could be used is going to certainly improve access for patient populations that may not have access to immunotherapy. But I think the next study, I do believe, to really look at a true benefit and look at the toxicity differences, I do think a phase 3 study would be needed. And the question would be, who would fund that study? Certainly an industry sponsor may not be as excited to fund such a study, but some type of a government or cooperative group study would be kind of some of the ways that we can tackle these questions. I do think it's an important question to look at. Overall, we have all been re-questioning the idea of these maximum tolerated doses for a lot of our targeted therapies. And I think really it's been top of mind that perhaps we can kind of give patients less drug therapy with less toxicity potentially and similar efficacy. But for this particular indication, I do think some type of a larger phase 3 design would be important to do.
好，我们再补充一个问题，也就
a follow-up question is that, so I mean, if we use the standard dose immunotherapy versus the low dose pembro, so based on CPS score, do you think it is possible for us to do stratification based on PD-L1 expression level? So for CPS score, can it be utilized to stratify the treatments to differentiate standard dose or low dose?
I think it's an absolutely wonderful question that needs to be studied. I think with Keynote 522, we only had the PDL status showing no difference in PCR status. However, I do think there are a lot of biomarkers that have not been systematically looked at holistically in this preoperative triple negative combination. So PDL status, tumor infiltrating lymphocytes, and other biomarkers, if we can think creatively of looking at the biology of these preoperative tumors, I do think there is a story to be found out where we could better stratify these tumors, those who can get less chemo, those who can get less immunotherapy. We just don't have those data. Part of it has been a lot of restrictions in terms of looking at some of these biomarkers in the Keynote 522 regimen and some of the other studies. But I think this is an opportunity potentially for international collaborations where we can potentially investigate these biomarkers and try to find the answer to your question. Right now, we don't know, but I think it's an important thing to study.
好，谢谢 Lasberger 教授给我们进一步的这样的一个解释。
Thank you, Professor Lasberger, for your excellent answer. And now we are going to move on to the last discussion topic. So, Professor Lasberg, in the advanced stage HR positive, HER2 negative breast cancer you have mentioned about, after patient progressed on CDK4/6 inhibitors using oral SERD, ADC, and PAM pathway inhibitors, how should we choose? Maybe we can invite Professor Yu Yang to comment first. Thank you for your question. For first-line CDK4/6 inhibitor plus ET, this is already the number one option for HR positive, HER2 negative advanced breast cancer patients. And we know, based on previous study, the first-line PFS is around 2 years. So what should we do after progression? I think one thing we need to understand is should we still use endocrine therapy? Because endocrine therapy, firstly, it will prolong the survival, and secondly, it can delay time to chemotherapy. So if we are going to switch to another endocrine therapy, maybe this can help us to delay time to chemotherapy. And now we have third, we have also other treatments that are more available. For example, we can use the CDK4/6 inhibitors cross-line re-challenge. So like the speaker mentioned, using palbociclib across different treatment lines or re-challenge is not really effective. And we can see some of the patients, they even using CDK4/6 after CDK4/6, but still they switch to abemaciclib or ribociclib and show some PFS benefit. I think this is very good. Now, after 2 lines of CDK4/6 inhibitors, if we add the 2 PFS after 2 lines, then we can have 30 months of PFS. Then what do we have after that? We have capivasertib, for example. This demonstrated that PIK3CA mutation is also very important. And also for patients without PIK3CA mutation, it's also fine. Only those with this mutation will benefit more. And what can we do after that? We can also think about, for example, ADCs instead of chemo. So in this case, if the patient had BRCA mutation, we can probably consider olaparib as well. So after we have run out of all of these options, then of course chemo can still play a role, because for advanced breast cancer patients, we need to think about how can we use the treatment to prolong the survival. Thank you, that's my comment. Very well said, Professor Yu. For first-line CDK4/6 inhibitor, after progressing on first-line CDK4/6 inhibitors, should we use endocrine therapy or chemo or ADC, or what should we do? So for this topic, I would like to also ask Professor Sun. So far, I think for HR-positive advanced breast cancer patients, now the treatment selection is more complicated. Now with more options means for patients, they have longer survival. And facing very difficult selections or treatment options, I think we need to emphasize on precision management. If the patient after first line had, for example, relapse or metastasis, we should use genetic testing to see whether there's, for example, PAM pathway mutation, and also test the BRCA mutation, etc. And also, so basically, I think we should perform genetic testing first. And also, Professor Jiang mentioned before that basically for HR positive patients, if they have a mutation, some of the professors, they don't agree with the testing in the adjuvant setting because they believe that it will only make the patient more anxious. And also for PAM pathway, because it's a driver mutation. So now, some of the professors may have different understanding about genetic testing, but of course, I think if there's a relapse or metastasis, I still think we need to do genetic testing. If there's, for example, PAM pathway mutations, then we can use everolimus and also other treatments. I think that's maybe a very good option. And for those with the ESR1 mutation, then re-challenge with CDK4/6 inhibitor. And if they have very long PFS in the first line, then re-challenge with CDK4/6 may be reasonable. We can change the ET, we can change it to fulvestrant or Orosurt if it's available. And Professor Lasberg mentioned that if we switch from fulvestrant to a different endocrine therapy, maybe the result or the efficacy will not be very good. But if we switch from tamoxifen to fulvestrant, the result will be better, in particular for those with longer PFS in the first line. But of course, even though we are going to re-challenge, but I think it would be better if we can switch to a different CDK4/6 inhibitors as well. For example, from palbociclib to ribociclib or abemaciclib. And for ADCs, when should we use the ADCs? And also chemotherapies, when should we use chemo? If the first-line PFS is very short, then re-challenge endocrine therapy may not bring a lot of benefit, then in this case, we can consider ADC. I think in this case, ADCs can be a good option. Thank you, Professor Sun. Indeed, for endocrine therapy and targeted therapy for PI3K and also PAM pathway, etc., I think we have treatment available like capivasertib, etc. So now, for DB04, DB06, the anti-HER2 ADCs, and also based on other studies, like the Dato-DXd series of studies for HR-positive patients, we have a lot of possible options, but still we need to have a very smart arrangement. I would like to take this opportunity to ask some questions for HR positive early breast cancer. For very high risk patients, we are now having more and more wider and wider use of intensified adjuvant treatment, not only abemaciclib but also ribociclib. So for these CDK4/6 inhibitors in the adjuvant setting, if after early intensification and the patient progressed, I think it's different from previous circumstances. So for patients who progressed on CDK4/6 in the adjuvant setting, what should we do after that? Would like to hear from Professor Lasberg. Thank you.
Yes, thank you for that important question. I think we are all very worried about this population. Thankfully, it will be a lower number of patients, but still we're going to see more of these patient populations as the use of adjuvant CDK4/6 inhibitors continues to rise. I think depending on how long it's been since they either completed therapy or if the recurrence is happening while on CDK4/6 inhibitor and adjuvant endocrine therapy, I think those are two different populations. But I think depending on how short those intervals on, I think one is also knowing their PIK3CA mutational status is important. So again, back to the genomic profile of the tumor, resampling the tumor, understanding the biology will be important. We have the iNovo 120 data, which is the triplet therapy with inovolizumab plus palbociclib and endocrine therapy, but that study was done before the use of adjuvant CDK4/6 inhibitors, as you rightfully mentioned. So, but I think if they do have a known PIK3CA alteration, I think depending on how long it's been, how active the disease is, how worried you are about their visceral burden, I think a re-challenge with some type of a targeted therapy approach could be considered in select patients. However, these are the patient populations that I think I would favor probably an earlier switch to some type of antibody drug conjugate switch since they've shown such aggressive tumor biology. But it's a case-by-case discussion. And I think if they have a known PIK3CA alteration, I may consider close monitoring on some type of that targeted therapy approach with a plan to switch them early, likely to ADC or chemo. If they're beginning to progress. They're a very vulnerable population, and we do need additional studies looking at predictors of how to best treat this particular population.
好，谢谢拉斯伯格教授。
Thank you, Professor Latsberg. I agree with you. CDK4/6 inhibitor in the adjuvant therapy, adjuvant setting after intensified adjuvant therapy, patients probably need to consider ADC early on and also more precise treatment or targeted therapy if there's an actionable target. And of course, there's more questions right now because we want to always try to achieve cure. And there's always more unmet needs and a lot of efforts still need to be made. And for today's meeting, we are about to conclude today's meeting. I would like to thank our two overseas speakers for your contribution. And I would like to thank Professor Yu and Professor Sun for your contribution, for sharing your insights in the discussion session. I believe for our future clinical practice, it will be very helpful. So it's already very late. It's already 9 p.m. China time. And I would just like to briefly summarize today's meeting. Now for breast cancer management, it's now become more and more precise, and the cure rate is increasing as well. So the key factor is how to implement the treatment, the guideline recommended treatment in a more standardized way, and also to have more humane touch as well. Because for breast surgery, we not only need to make sure we have clear margin, but also breast conservation and reconstruction, and also consider comprehensive management to achieve higher cure rate and best quality of life. Finally, I would like to thank Professor Yu, Professor Sun, and our two overseas speakers from online, and all of our audience joining from online and on-site. I know for our Chinese doctors, I know you've been working really hard, and also you've always had passion to learn. Thank you very much for your attention as well. Thank you and goodbye.